and found that out. I didn't realize that the person had started doing that.
All right, I think we're going to go ahead and get started. Welcome, everyone. It looks like we have some announcements first on the agenda before we get to the meeting minutes from our last meeting. So, Desi, are you doing that? Or
Dan's going to do it.
Okay, perfect.
My name is Suzanne Schaefer. I'm the Director of Nursing, and I am just letting you all know that after some careful consideration, which included contacting the local health facilities in the area that provide the same service, it has been determined that Fargo Cass Public Health will no longer be providing our international travel clinic in the clinic. Sanford has a full travel clinic, and they have recently grown due to the fact that they are the local provider for yellow fever vaccine. We can't get that any longer at this time. So our numbers have declined considerably over the last year. Essentia also has 2 infectious disease providers that will take travel clinics on their schedule as well. So our last clinic date at this point will be May 16th.
Okay.
Any questions?
Any questions? As far as sliding fee scale, I mean, are the other health systems willing to look at that? Or
So
I'm just concerned about those that wouldn't have.
So our international travel program, the vaccines that we give for those are not on the sliding fee program. That would be the other vaccines that we give.
Okay.
However, that was Sanford was giving people that information that we were sliding fee, and we never have been for international travel. So
Okay.
that was a little bit of a misconception out there.
Okay. Okay, thank you for that update. And thanks for all the work that you have done over the years with the international travel program. Excellent. Okay, next on the agenda was minutes from February 15th. Wow, that was a while ago. Any changes, edits?
Motion to approve.
And second?
Second.
All right, all those in favor say aye.
Aye.
Any opposed? All right. Thank you. All right, budget is next.
So Melissa's off today, so you get the really downed version of this, but you have that in your packets. Things of note that she just wanted to let you guys know, she did on the revenue statement now, she did add in, if you can see the second column, there's some that have a Q placed there, so that just means that those are ones that come in quarterly, just so that kind of helps us know if there's an area that's a little bit lower, why the revenue hasn't come in for those yet. Also, she was looking at revenues for this time of year compared to last year, and we're basically, revenues are at 12%, it's down like 1% from last year, and expenditures are at 23%, which is down 2% from last year, so pretty much on course for a normal year for us. And we do have our budget process starting soon, so the middle of May, we will be meeting with division staff and having them look at their budgets. And then we have our Board of Health budget meeting at the end of May, which you all will be involved in. And then we meet with the city team on the 29th of May. So we will be starting that process for next year. Questions?
Any questions? Okay. All right, they went easy on you.
Good. They know better, I think, it's probably why.
All right, Justin, agency plan progress reporting.
Okay, so at the last February meeting, we went through, just briefly, was the 2-year progress report for our community health improvement plan. We saved the questions because there was the TV presentations. But today, I have Robin Litke-Saul. Can you raise your hand, wave to us? There you go. Cheryl Stetz and Michelle Draxton. And those ladies were the ones that are primarily working the activities that we have on our improvement plan. So if there were any questions, these are the ones to ask. They're much smarter than I am, and they will have much better answers, but also just to recognize them for their hard work.
Perfect.
Okay.
Any questions? We did have a pretty full agenda last time that we met,
Yeah,
so.
yeah, it was pretty packed, so.
Looking at my notes, I don't have any questions written down from last time, but anything? Okay.
Okay. I do have just a brief run through of some of our other agency plans that we are working on. The way we had done them last time was that after the last health assessment, in the next cycle was when we would refresh them and review them, and then look at our objectives and our goals and see what we can change and modify and maybe fit better. Especially with Desi as our new director, her vision of what she wants to put forward for the agency as well. So we have a workforce development plan, which was a lot of focus on working on Launchpad, that internal learning management system that we've been using, which has been good. I think there's definitely an ongoing piece there that we will work on because, new technology, new functionality, putting things on assignments and stuff like that, there's a learning curve for all of us. Working on QI is another big piece. We have monthly meetings that we are transferring our staff through, people from different divisions. There's divisional programs, there's division projects. I think there's 2 or 3 going for a couple different divisions. As an agency, the customer survey has been the one that we've really wanted to focus on for our full agency for now. We are trying to do more training, so it just breaks down the confusion, some of the intimidation with QI, because if it fails, then it's a failure, but no, it's still a success because we're still doing something, we're learning new things. Our priority plan, strategic plan, enhancing community awareness and understanding through increased visibility, which has been part of another QI that Health Promotion has been doing with social media and working on messaging and all those kind of pieces and planning, which is Holly Scott is here, and she is our communication specialist, so she's been helping with that as well, so we can make sure that we're getting her good information and making quality posts. Employee engagement, job satisfaction, as you know, we've done our employee survey, and we are working on goals and objectives and following up on that. So there's still that engagement level, which again will probably remain on our strategic plan as we do annual updates. Culture of quality improvement, performance management. We've done really well with quality improvement as it's been a monthly thing, and then performance management has been, again, connected to that piece of the survey where we are, the managers, the directors are primarily that executive group, and then we're working through that survey and then coming out with more goals and objectives. I know I'm talking really fast, so I apologize if I run through it. And priority 4 was obtain and maintain national health accreditation, which we are still in the process of. And I have my little whiteboard of anxiety that I have up on my wall, so anytime you'd want to come to the office and see it, I'll gladly show you where we're at. But we're making progress and we're marking some stuff off, so we're doing good.
Is there an end?
Well, December is the end. That's our deadline. But
Okay.
the sooner we get it done, the sooner we can say we're done. But I imagine we'll probably, check, double check, triple check.
If you could say that if there's one major barrier, what would that be as far as getting that completed?
Gosh, I don't know. There's sometimes with the new policies and stuff, making sure that we're writing them for accreditation reasons, but also that they need to fit for us, not just making paperwork to, jump through the hoops. And we're trying to be very cognizant of that as we're going through it, that there's meaning for us, there's value that we're doing things. There's already been one checklist that I'm not the biggest fan of, which Suzanne smiles because she knows what I'm talking about, that FAB would like us to do. And it's, it's definitely one for them, not necessarily a whole lot of benefit that's showing for us. But, we do our thing. So we're going through it. And again, familiarity with some of the legalese that they kind of type it up for accreditation has been challenging at moments, but we're doing well. I think people are getting a good grasp of it. Right, guys?
Okay. Any questions for Justin? Okay. Well, policy work isn't easy, so.
Yeah, it's kind of fun. Everybody else groans when I say them, but it's fun. Thank you.
Well, I'm glad you like it. All right. So a flood update. I don't see Doug, so.
Doug's not here. Doug actually is participating in So he went out to Washington State. I don't know if most of you knew that, but he went to help with the measles outbreak there and worked in their Department Operations Center. And so they're having an after-action meeting today, so that's why he couldn't be here. And I realize this isn't like super applicable anymore. When it was on the agenda a couple of weeks back, we were more in the middle of things, but now it's kind of winding down. But I did think there would be some value in just sharing for you guys what we typically do in a flood response as a health department, because that has, years ago, we were like tetanus shots. That's all we did. We wouldn't really participate in anything else. Our role has changed significantly, and probably most of that falls on Doug and his emergency preparedness staff. Some of the roles that we do handle from a department-wide, when they start up Sandbag Central, we will do some supervision of workers and process when we're out there, so we send people to kind of fill those needs. We also have staff that would go and help in the Emergency Operations Center, kind of just as an assistant to Leon, just to kind of make sure things are getting done. And then if all ramps up, then we would open our own Department Operations Center within the EOC. Usually we're across the hall. And we, at that point, then are charged with the vulnerable population in our city. So we work with community partners that handle those populations. So whether it's long-term care, Southeast shelters, various agencies, we kind of work together with the hospitals to make sure that they can keep providing care as long as they can, that type of thing. We're kind of that liaison, and Doug's staff really is considered a state response team, so they are working very closely with the North Dakota Department of Health on their, making sure that everyone has their emergency plans in place. So we don't go in and tell them how to do something. We do assist in them developing plans and making sure that they're utilizing the state assets and the state mass communication systems and all of those pieces. We are kind of that coordinating piece. But, and yes, we do still give tetanus shots, but it's just a little side job. But, so our involvement has increased significantly over the years. This was a really, obviously, it probably impacted the county more than it did the city. And Chad, you can speak to that when I'm done here too, if you'd like to. But just our role in the whole thing has just been to make sure that we are that kind of coordinating that tie-in piece between knowing who the vulnerable population is and who's caring for them and how we can handle that if we would need to. Any additions for county that you want to throw in?
Sure, not particularly, but I do have an interesting observation that doesn't really pertain to this subject, if I may.
Sure.
So I always note that we go out and hire people nationally, that we don't hire people locally as often as we should. Like when we look for administrators, we always do these nationwide searches on things. So why is this person off in Washington? Why is Doug off in Washington? Is he an expert in this?
So with that statewide response, so Doug's position is funded through the state health department emergency funds. So within that contract, they have a little bit of a clause in there that's kind of like if there's national needs that we will help, assuming then that people then may help us. So one thing that our group has done really well is they're really good at what they do. They talk well with each other. We work well with among other agencies, and I think people recognize that about North Dakota. And so when they have needs, they sometimes put out those requests. So does he have to go to all of them? I mean, he gets a lot of requests and can kind of pick and choose what he wants to participate in, but at some point he usually does go. And so this was one that he chose because of the setup of it, and it was kind of a controlled environment, whereas, you know, some of the other ones, if you're going for hurricane relief, you don't really know what you're going to be doing. He knew he would be in a Department Operations Center atmosphere, and he was excited to help with that. So that's, you know, so it was a week long, I think, that he was deployed. But yeah, that's kind of how that happens, is because I asked the question, like, how does this work? And I got a really strong answer from the State Department of Health saying, here's the part of the contract that says we can pull them whenever we want, so.
Yeah, I'm not, not questioning that at all, but I guess I'm making the point, validating the point you just made was, it's amazing how often we find we have experts living next to us. Because there's a lot of people they could have called and asked for, and I realize they'll probably do timeshare and they'll swap some hours here and there from Seattle or from where.
Yeah.
But from our sheriff's department to local leadership, obviously I'm a county guy, so I know on the county, nationwide, I sit on 2 national committees. We've got our auditor, Mike Montplaisir, and Charlotte Sandvig, who's our treasurer, just retiring. Actually, retirement party later today if you guys want to get a little bit rowdy with your former treasurer. But it's always so impressive that we seem to ignore the talent we have locally when we go to hire the big leaders. And I wish we didn't do that as much. For our diversion right now, we're looking at an executive person again, and it's not to say we discount our local talent, but boy, the last guy we looked at was a fellow from Virginia or something, and I don't know. I think we've got a lot of skill sets here, and the nation always seems to call us, even though we're such a small portion of the population. I'll stop there, bye.
And actually, the really funny part about that is that, of course, when he was down there, they had the snowstorm of, I don't remember how much they got, but no one would drive, and so Doug actually took the rental car, which was an all-wheel drive, and went around and picked up people because no one else knew how to drive there. So that skill was helpful as well.
We're resilient.
Yes. So yeah, they do really good work.
Excellent. Any other questions for Desi on the flood fight? I do have one question. You know, one of the things that we struggled with back when I was involved in the health department was just the identification of those that are vulnerable and how to get them out of their homes. So I'm just curious how that has evolved.
Well, it's gone a couple of ways. So a few years back, you know, we started a vulnerable population registry, which was a super good idea at the time. What it turned into was a friend of a friend calling in for someone else, and then that person finding out they were on the vulnerable population list, and that person calling us back mad that they were on this list because they're not vulnerable. It was really hard to, and then a lot of people that got on the list were already working with an agency, and that really wasn't who we were trying to find.
Right.
So we want to know the people that are out there that maybe don't have the resources to get out of harm's way, and that no one's working with them, and those are really hard to get to self-report. So there just didn't seem to be enough momentum to maintain this list because we weren't capturing who we were supposed to. So, I mean, really what we try to do, like if we would have gotten to that point this year, with the flood line that First Link manages, we would have had people calling in and self-identifying at that time. And then hopefully there's enough word of mouth out there and people knowing maybe who your neighbors are, that type of thing, where you could kind of give the heads up in those circumstances, but it just didn't work to have the list. So is there still a gap in that? Probably.
I'm just thinking about, I don't know that if we have an idea of the volume of people that would self-identify if we're in a crisis mode. Follow-up question?
Yeah, well, more along that line. So when we were out doing our regional or area meetings, Jesse Johnner, our sheriff, really reinforced, do not be afraid to call us for help. That's what we're here for. But people don't call. We don't. So there's a lot of good up here, right? But the resilient has some bad, and the resilient bad portion is we don't want to ask for help until the house is about to get knocked over by the water. So we really try to stress, please call. It's what you're paying taxes for. It's our job. We actually like this. So we like helping you. It's kind of our gig.
Yeah.
So it's hard to impress upon them that they have to call ahead of time. And I don't know what you can do, to be honest.
And you actually have to gather enough information so you can go in there with the right resources. So if you have someone who has, bariatric issues or, you need transportation that can meet the needs of the people. And so it's not just knowing that, yeah, there's someone in that house and we can go in a bus and get that, it's a lot more than that. So it's challenging.
Okay.
Quick question. I have a process question. So this organization, excuse my braces, is very involved in emergency response, obviously. Do you have emergency response plans, or do you sit at the table to help coordinate those?
If I'm looking at Justin because he's going through those right now.
And I'm thinking about floods. I'm thinking about a potential measles outbreak.
Yeah, so there's plans in place. So we have agency plans, and then all of these community partners have their own emergency plans. So the emergency preparedness staff is working with them not just in flood. So they're working with them all year long. They do exercises with them throughout the year so that to help them in exercising their plans. Help them in identifying, okay, what's your safe spot? Your building goes down, where do you go? How do you get there? That type of thing. So the community has their plans, and then we have our plans of addressing, yes. But do our plans need a little work? They might. Yeah. And the other hard part, which he's experienced this pain as well, is, some of our plans go to a certain point, and then it kicks to the state health department. And there isn't necessarily a clear delineation of where it kicks and how it kicks. And so those are things we need to work on.
That's been a challenge through accreditation is really defining roles and at what part, like, our role stops and then state takes over, and we have a memorandum of understanding that we've been using that, gives us a little bit, but not really, for accreditation efforts, they don't see that linkage. So that's one of the parts we're trying to, be a bit more explicit and figure out and define. Plus, sharing plans of where state their role and then defining everything that their protocols are going to lay out is also a part that we are really going to need. So I have been bothering State Department quite a bit. Yeah.
Other questions? Okay. All right. Jan, harm reduction update?
Yeah, hi, everyone. In reviewing the numbers don't necessarily reflect, or they reflect such a small fraction of what we actually do within each one of our programs. I think one of the things that's been really notable the first quarter of this year has been the number of people that we served because of the weather throughout much of the winter months. Typically, we would be somewhere between 780 and about 850 beds provided for those first 3 months, and you can see that under the nights of shelter, we have significantly higher numbers. We actually served more people than we ever have, I guess, during the cold season. We had a couple of nights where we had over 50 people in our building, which is a lot of people to have in the shelter side of things. So it's definitely came with its challenges, but we made it through that, and we're starting to see fewer people accessing or needing to access the shelter at night, but it's still pretty significant. Notable thing about homeless outreach, I would say, is the trend that we've seen now over the course of about the last, I'd say, 6 to 8 months has been the people that Jillian is interacting with from her position out of the library are people that really aren't connected to any shelters or any other case managers anywhere. So when she brings those folks' names to the table for consideration over housing and prioritization, really nobody else knows them, and that's really unusual. In the past, we've had enough of us out there where we've typically known most everyone that was homeless or is homeless, but at this point, we're seeing more and more folks that really aren't connected to anybody other than Jillian. She is going on maternity leave, so we are frantically planning to cover her position to try to make sure that those folks who really only have that connection stay connected and keep moving forward with whatever their goals are for housing and so on. syringe services program, we've seen a considerable increase in activity each one of the months of this past quarter, and a lot of it really exciting changes going on there. We've taken a look, now that we've got about a year behind us, we're taking a look at what can we change, what can we do differently. We're trying to be a lot more deliberate in tracking some numbers that we really hadn't thought about tracking in the beginning. For example, the number of people that are receiving services through secondary transactions. We've been taking a look at that. And an example of that would be, we have 27 participants at the Harm Reduction Center in the Syringe Service Program that have identified as doing a lot of secondary distribution, meaning they're getting the things that they need to keep safe, but they're also getting extra so they can provide other community members with those items. And we have about a total of 27 individuals doing that, and we've identified about 175. This is, of course, approximately because it's by report. 175 individuals that are receiving services from that secondary standpoint. So those are folks that aren't coming in. We continue to try to encourage those folks to come in and talk with people about encouraging the folks that they see outside of our services to come in. And we are starting to see that a little bit at a time, but we have to build trust in the community and stay true to our mission so that people can start to feel a little bit more comfortable with coming in instead of having to rely on other folks coming in for them. We've also, the other thing that we're really trying to track is the number of saves that are being reported to us. We've distributed a considerable amount of Narcan throughout the community through the Harm Reduction Center and a number of other programs, I guess, which Robin can speak more about that. But to this point, in the first quarter, we had reports of 53 saves occurring, and of those 53, none of those were reported, or none of those were 911 calls. That's where individuals are using the Narcan that they're getting through our services, through public health services, to save somebody else that they're with at the time. So I tell people all the time, we know that there's been a reduction in deaths by overdose in our community. I think that overdoses are still happening, but I think that, if we look at the numbers and by, in talking with the folks that we're serving at the Harm Reduction Center, I believe that fewer people are dying because they're saving each other, and that's a primary factor in the reduction in deaths by overdose. So I think that's been a really significant change compared to last year at this time. And testing, HIV and HCV testing, the numbers there seem really low when you just look at them, but we put a lot of energy into an option that we were able to work out with public health, where there was some incentives to get people into public health to access services, get tested, hear about all the different services that public health provides, everything from family planning to annual physicals, and that was a very popular program. So we're going to try to figure out where we can find some dollars to keep those incentives available. People were very interested, and we had a couple of folks find out, a change in status in terms of HIV or Hep C. We also had a couple of people find out they were pregnant because of that program, and so that was pretty exciting. And so while the numbers on here don't necessarily reflect that, we've definitely made a huge jump in those referrals to get people tested and get access to other health care as well. Any questions so far? Because I could just go on and on.
Chad?
Couple too. So I realize that people that are not reporting the Narcan saves probably aren't concerned about statistics and data. That is imperative for people like me, because obviously we're now litigating, I should say, not advocating, litigating and advocating for additional resources through, this lawsuit that we're in, the opioid lawsuit. So the more data you can provide to us, the better. And again, I realize it's not necessarily their priority, but
Sure.
And how you coerce that out of them, I don't know.
Right.
But do your best. Other one is, you said there's a number of people that have no connection locally to anybody that were at your shelter. Who are they and where are they coming from and why are they coming here?
No, the folks that don't have any connection that I was talking about, those are folks who are only connected to our outreach services out of the library. So that's true street outreach. So those are folks who are not staying in any shelter. Sometimes there's endless number of reasons for why people may not access a shelter. We don't always know where they come from. A lot of folks that we interact with have significant challenges related to mental health, to behavioral health. Sometimes we never find out where they came from. Sometimes it takes us just months and months and months to get any idea of what brought them, or where they're from, and if they're not from here, then what brought them here. Typically, if they're not connected to anybody else, it's highly likely they came into the community from somewhere else. I've met people who have literally gotten on a bus, or somebody's put them on a bus somewhere else and sent them here. So it's tough to track. It's really tough to track.
It's a fascinating study, I guess, obviously, just to figure out where and why. I think it's fascinating why you'd come to Fargo, North Dakota. And like, I know some people, we had a gentleman reported, and I don't think it was you that told us, I think it was social services, but when the boom was happening, there was a veteran up in Minot. They just put on a bus and sent to Fargo. City or county paid for it, and here this gentleman is. It's just
Well, and during the boom,
shocking.
people, we had both interstates running through Fargo, and people really got off the bus, or however they got, if they had hitchhiked or whatever, not realizing how much further away the oil patch was. So they were all pretty surprised to hear some of that. And some people ended up staying here because, I think that the majority of the people that I talk to who come here who don't have homes when they get here are people who were really looking for, they wanted to improve the quality of life. That they had better opportunities to improve their own quality of life by coming here, and Fargo and North Dakota had an awful lot of coverage, media coverage for a long time about quality of life and safe place to live and jobs available. And if you're existing someplace where those things aren't the case, then coming here, I know I get a lot of questions about why people would ever come to such a cold state if they don't have a home and so on. People will go wherever they can if it means that it gives them an opportunity they don't have wherever they, even no matter how much the sun shines elsewhere. So, and then there's folks I think who have preferred to, they just disappeared from wherever they were before, and I guess we have that right to just disappear from the lives of other folks, and I've certainly met a number of those folks, I guess, in this work. No matter what, our number one goal through our outreach is to move people from the streets to housing as absolutely as fast as possible. So we right away start working on document readiness. That's the biggest challenge for most people. They don't have all the documents necessary to apply for housing, to apply for jobs. Even a day labor job is unattainable if you don't have adequate identification. So that's what we start working on right away. And that's what Jillian starts with right away. That's what most people start to come to see her for initially. And then through the development of that relationship, they start taking a look at other things. So it's a pretty natural process and effective. Did I answer?
Absolutely,
Good
and
deal.
then some.
Yep, that's usually the case when
I'm the same way.
So other things, withdrawal management, that's remaining pretty steady. One of the exciting things is our mobile outreach unit, which again is a pretty unique program in the nation. We did receive funding from Department of Human Services to expand that program, and this week we expanded to 16 hours a day rather than the 8 we had been operating. We'll probably be adjusting those hours to do a little bit of overlap in the middle of the afternoon, but it's amazing how we can keep the folks in that vehicle hopping. So there's just never a shortage of anything to do when it comes to responding to crisis in this community, especially crisis related to substance use. We continue to get a lot of really positive reports, especially in the downtown area. People who live and work downtown have just given us a ton of great feedback on the reduction that they're seeing in all these crises. They're not seeing as many ambulance calls. They're not seeing as many interactions with law enforcement. And we believe that's because of the increase in our presence downtown through mobile outreach, the Harm Reduction Center, and just really trying to get out there and getting out of the shelter and being a lot more assertive in our engagement with folks. So I think that transport numbers, they could be, if we had 5 vehicles, they would still be high numbers. So there's just never, between emergency rooms and all the other services in town and just the number of people that are living in crisis in our community because of substance use, we could just go all day. So we'll keep working on that. It does make a difference. We're able to have conversations with people and get them connected to services because so much of that program is about engagement and relationship building. And we're having a lot more conversations through our Harm Reduction Center and through mobile outreach with folks about treatment options and just anything that's related to their own goals for recovery, and that's making a huge difference. We're seeing people move toward those things in ways that we haven't seen before. So it's exciting to be a part of that type of trend. Presentations, we do a lot of presentations. That's underreported because the rest of us are horrible at paperwork, and Robin's really awesome at it, so her numbers are always there. But we do have some other things. We are presenting next week at a harm reduction summit in White Earth. We have two different presentations there, one on mobile outreach and the other on harm reduction services and our syringe service program. So we've been asked to present at a number of different conferences in the state and elsewhere because we do some pretty unique and creative things, and I think people are excited to hear about those. And we always speak to the support that we receive from public health in the city of Fargo because it's not like that everywhere either, so. And I guess do you have any questions on any of the other areas, or?
Other questions? I know, Jan, you weren't here the last time, but we made note of Giving Hearts Day. That was awesome.
Yeah.
It was great. So hopefully well, I'm sure it's being put to good use. So.
I am sure it is too. Yeah, that was very exciting. It felt pretty good. It was affirming for all of our staff and for the guests that were involved in just trying to make that a big deal, that people in our community wanted to support us. So that was very exciting.
Yeah, definitely. I do have a question on the incentives. I'm curious about the testing piece that you talked about earlier in your presentation about just getting people to go into public health and get those various tests and identify some things that they didn't know. So the funding, it doesn't seem to be there any longer for that, or can you talk a little bit about how that worked? Or Larry?
Sure, yes, I'll discuss that. Jan and I have met numerous times about the importance of individuals knowing their status and getting tested. So I reached out to the North Dakota Department of Health Division of Disease Control and asked if there was some funding available so we could get a variety of individuals who we felt would be important to get into our clinic to be tested. We did share with the North Dakota Department of Health our ideas on what we were thinking, and we called it a pilot project, thinking it would go well, but just looking at it and adjusting as needed. We were pleasantly surprised, I was, of how receptive many of the clients who utilized the harm reduction program were, because for a variety of reasons, there are reasons why many individuals do not seek out health care, do not want to go in and get tested. Are they scared? Are they, do they think they're going to be judged, or whatever they're the reasons? So part of the goal too was not only to get them in the door and provide a gift card for them to be tested, but at the same time, hopefully building a relationship. So next time, maybe we won't have a gift card, maybe there won't be an incentive, but they remember that the staff cared about me. They provided good quality care, and I'm okay going there for. Maybe it isn't just for an HIV test or an STD test. Maybe it's for an immunization or some other service, but the staff at Public Health treated me like a person. And we just wanted to build that relationship because, again, hearing some stories, that might not have always been the case for some of the clients. So the feedback that we have received from clients and the staff from the harm reduction program, they felt that it was extremely positive. So as we move forward, I think there'll be more and more, hopefully, opportunities to build that relationship and get more people through our doors.
Sounds like, you had results. So, to Chad's earlier point about data, and if we're seeing good results out of that, you would think that the Department of Health would be willing to fund that on a more substantial basis.
Yes.
So, okay, excellent. Any other questions for Jan? Okay, next we have a legislative update, and I know that Robin has an update as well related to Fargo Public Schools, but I wasn't sure, Desi, if there was something.
Yeah, it's obviously been winding down. So.
Tonight or tomorrow morning, is what I'm hearing.
I was told Tuesday, but
Oh, really?
I don't know.
Okay.
There's a
I
pool.
was also told the 20th, so who knows?
So yeah, I guess the thing we've tried to do a little bit different this year is just to be a little bit more involved and to like for Public Health Day, for example, Justin developed a kind of just a flyer with all of our, our managers and stuff on it, what programs they did, a little bit about the health department, just kind of, and we sent it to obviously our representatives just to be like, this is who we are and this is what we do, and please contact us for issues. And then we've tried, as things have come up, whether it's, tobacco tax, various things, we would just kind of send saying, this is what we think, this is how it impacts public health, and, just so that they could be informed and know where we stood on things. So, I can't say there's been a huge win for public health this year or, huge loss for, it's kind of just been one of those, not a whole lot changed, but like primary seatbelts, things like that. I mean, we got close in one and then we lost in the other. So it's just, but you continue to provide the message and why it's important, and hopefully next go round it gets a little bit better. So the last thing that we had sent some correspondence on was, of course, the House Bill 1004, which is the North Dakota Department of Health budget, which, the good thing is that our state aid funding remained level, because that initially was going to be cut pretty significantly. And then they had a portion in there of some CDC grant money that was going to support some opioid work, more so in those regional collaboratives that we have established. And there was a little bit of dissension amongst the legislators because of this funding. This funding required that they use a particular tracking system, and the Board of Pharmacy already has an established tracking system, and so it sounded like there was some logistical things that got in the way. We had sent a response saying that, this money would be great, this money would help, especially, it was going to help Grand Forks start up a syringe services program. It was going to kind of do things across our state that would have helped in our opioid efforts. I did get a lengthy response back from Senator Lee, who was not in support of the bill, and so responded to me and forwarded it to everyone on the list with what her thoughts were on that. And it was just, I think there was really strong opinions one way, and there was really, opinions on the other side. And the strong opinions on the, we are not going to be forced to use this particular tracking system, and that's more money than we're paying right now. And so it wasn't going to go anywhere, which is unfortunate. But I had a couple other responses saying, yes, we support this and we think it's a good idea, but it didn't pass. So it got signed by the governor without that funding in it. So, those regional efforts will have to hopefully look for other sources of fundings to start up. Because the syringe services was one that was passed, to go forward with in the state.
Okay. No, there's a lot of behavioral health ones that got rolled into the DHS budget bill too, that I've heard is pretty close to being finalized. That's why I'm thinking it's tonight or Saturday, because that's usually one of the last ones. But a lot of like peer support specialist certification and things like that I think will be helpful. So.
Yeah, I think there will be some opportunities for Jan's group to maybe, expand and recoup on some of their efforts that they are already doing, so.
Okay, perfect. Robin?
Sure. A couple of the crossover topics that from Fargo Public Schools that crosses over into this audience. One of our main legislative priorities was behavioral health, because it's so impacting our schools. Behavioral health was rolled into the foundation aid formula for per pupil payments, how public schools are paid for each student, and that was spearheaded by a local senator. That was a freestanding bill that was rolled into that funding formula. So that was one of our priorities as a legislative priority from the school district. Also, incidentally, I'm the governmental affairs chair for the Fargo School District. And so, Justin, I don't know what kind of legislative systems you have in place, but we have a pretty smooth running machine and refined this year, so I'd be happy to share any of our techniques with you. We send weekly updates. We have different legislative forums, and it seems we're making great strides in our advocacy effort, so I'd be happy to help. I shouldn't have said, this was not one of our legislative priorities, but it became a priority of my time about guns in schools. And so we took some very strong stands on those, and one bill did go through that allows what it's called an armed first responder bill, and it's a very in-depth bill, and we didn't oppose it because it really is targeted towards some of those more rural districts that don't have ready access to law enforcement, and it leaves those the permission up to the school district whether they can have an armed first responder, and typically those would be already somebody that is employed by the district, whether it's a superintendent or a gym teacher. Nobody can be forced to do that. We don't have that in Fargo Public Schools. We don't expect to utilize that because we have school resource officers. But that was the only gun bill that sneaked through. I shouldn't say sneaked through. That passed through. But we did get rid of a lot of really, really poor legislation that would have endangered our community and our students. So I stuck my neck out and got pretty public on some of those. So I'm willing to continue to do that, but would be happy to join efforts on some of those other pieces as well. And then some interim efforts would be effective as well. So we should have coffee.
That sounds great. Thanks.
One other thing I want to mention, so the interim health reform committee is going to take on a study for comprehensive health care. So I would encourage that public health be at the table for those discussions. Certainly the health systems and health insurers will be, because it's going to look at a lot of the costs associated with healthcare. We all know the parts that social determinants of health play and all of that. So that is will be coming down the pike as well. So, all right. Any other questions or comments in the legislative update? Okay. All right. Any other topics, questions, thoughts? Okay. If not, we got our next meeting on May 31st.
Yep, so that's
So
our
coming up.
budget.
Okay.
meeting.
Perfect. And it will be here, correct?
I believe so.
Okay. I know in the past, the budget meeting has been over there.
I'll have to check on that and get back to you. How about that?
Okay. All right. Great. Thanks, everyone.
Thank you.